And basically, I bring up concussion protocols when we're talking about in the section here where we talk about evaluation-based protocols, because it's like, well, why do we only do that with concussions, right? And then, we're not really consistent with using the FMS or any type of movement screening thing across the board. It happens, in pockets and in spots, right? But we're not doing that consistently. So I like what you just said about the outcome measurements, right? So when you really look at the evaluation-based protocol, right, like you just said, being proactive and being able to do preventative screening, which we did talk about this a couple of times. There's a real good study in the journal of it was the North American Journal of Sports Physical Therapy by Maffei. I think it was 2006 or 2008 that looked at these pre-participation screens and how much effectiveness that they actually do have, and how and the like rationale for doing them, and then also like the idiocracy of us not doing them. Right? It's like we know that this stuff is really beneficial. So when it comes down into the assessment portion, right, one of the big parts that is typically skipped over or kind of diminished in terms of its importance or significance is the history taking, right? So in the research shows that history taking typically is 80% of your, and ends up being 80% of your diagnosis and your prognosis comes from the history taking. But when it comes down to the physician, usually they spend less than a few minutes of talking to a patient about the history, right? And then typically while they're taking their history, it's something like they interrupt the patient every like 15 to 30 seconds or something like that. So as the patient goes to speak and tell them whatever's going on, the physician interrupts them. So when it comes down to these outcome measures, right, they end up really being a part of your assessment and a part of your, history taking, right? When you're filling out, do you have pain in your back when you bend over? And if you're using the Oswestry back pain or Oswestry neck pain disability indexes, each one you have the lower extremity functional scale for the ankle. What's that?
This body and
yeah, the IKDC, you have all of these, right? But they're a very useful tool in your evaluation-based protocol in just in general to get that history taking piece. And then you want to also compare, because there's also studies that show that people will self-report differently when they're speaking to somebody. So, and some of it has to do with rapport. We will also see that patients and clients are more forthcoming with information when they're working with their PCP versus a specialist. They're also more likely to sue the specialist versus their PCP when you have malpractice, which again, it comes down to this relationship thing. So you want, because the history taking is so important, you want to be able to get the most information that you can get, from that history to determine what you're going to do with your prognosis, right? Or excuse me, your diagnosis and then your prognosis, right? So then comes in your assessment, right? And so in each situation is going to be different, right? And that's where, the history taking should help dictate your assessment. So in evaluations, you have kind of this, this exhaustive type of assessment or evaluation in totality that you can do, where, especially like in PT school or in school, you're going to look at every test, right? You're going to go through all the impingement tests, and you're going to go through all the slap tests, and you're going to go through, every range of motion test and every manual muscle test, right? But, as you get more seasoned, you start going through more of what's called this pattern recognition, right? So a lot of that can come from your history, not only watching them move and having them come in, to the office and the things they're doing from those types of patterns, but also taking the history helps you to understand what pattern, because you hear the same type of, responses. For example, having nighttime pain with a shoulder injury is very highly associated with rotator cuff tears, right? So when you hear that, you start to get into that pattern, which also sometimes creates some bias on more, experienced and seasoned clinicians. But, going through that pattern, you're more likely to kind of get to the point faster on the assessments that you're going to do. And then from there, right, after you do your history and your assessment, it's time to evaluate. So that's when it's time to sit back and go, okay, what's the prognosis and how am I going to intervene here? Right? And this is where it comes down to having a why for everything that you do. So if you need more whys, right, you need to do a more exhaustive type of evaluation, but you should have a why for everything that you're doing in your intervention. It doesn't have to be complicated, right? It just needs to be some type of rhyme or reason or rationale for doing what you're doing, and not just saying, oh, we're just going to do this because we've always done it, or I read this book and it said this is the way, this is the protocol you're supposed to follow, right? That's the difference between using a time-based protocol and an evaluation-based protocol, is that we're doing this evaluation component to try to determine how we are going to act and intervene and respond. So from there, everything depends, right? You're going to try to come up with this list of the most important things relative to their goals. So that's the other side, right? Because a lot of times us as practitioners, we end up treating ourselves. This orthopedic surgeon I worked with a while back, kind of gave me this nugget a while back. And it was funny because I didn't really need the nugget, but I always remembered this, that I'd already been through all my, high level training at this time. But he said, you got to be careful because we have a tendency to treat ourselves and not the patient. We want to go, look at all these fancy tests that I know how to do and all this different stuff. And all the while, it doesn't have a lot to do with the patient. Or when we start getting into our goal or into our interventions, right, the modalities or whatever exercises or stretching and manual therapies that we're going to get into, we're doing the things that we want to do, right? We think, okay, well, this is the cool thing I'm doing. Maybe even subconsciously, you're just practicing that thing, but it has nothing to do with their goals, right? So, understanding those goals during that history taking, right, is a part of this evaluation process. So then you can pair up your manual therapies and your modalities and your home exercise program and all of those things with the most important parts. Now, the biggest component of this that everybody misses that causes a problem, especially when it comes down to the return to sports phase and just success in life in general, right? If we're going to do a business plan or anything, we're going to start with a needs analysis. And I think people are catching on to that these days. It's like, we need to start with a why behind this. We need to start with a baseline type of screening or something like that, right? The world's kind of getting onto that. But where we fail the most is doing a reassessment, right? And a reevaluation, and not going back and going, okay, because of what I was seeing on day 3, is this the same as what I'm seeing on day 20? Right. And also when it comes back to sports injuries, we know the hardest time to diagnose them is in the first couple of days. Right. So within that 7 to 10 day time period, the evaluation starts to become more clear. Right. But having a functional prognosis in that early phase is also really challenging. So we have to keep coming back and reassessing the situation to see where they are. Maybe we need to take a step back. Right. Or maybe we need to progress forward. And when we're following these time-based protocols, you're not going to end up doing that. You're just going to go one step at a time. So there's a need for more frequent reevaluation during the evaluation-based protocol. And guess who else needs that reevaluation? The patient, the client. They need that feedback, right? The feedback that we give them is one of the most powerful things that allows them to build their self-efficacy, because they don't know. They don't have that unique body of knowledge that we have. That's why they're coming to us. So we have that fiduciary responsibility of doing the right things for them and giving them the right information so they can have that peace of mind to move forward. Where, there's this I can't remember where I got it from, this kind of story or quote. If you want to have somebody run really fast, if you want them to sprint, right, you need to clear the path for them. You don't want them worrying about stepping in a hole or on a piece of glass or something along those lines. If there's a bunch of glass and holes and danger, coming back to what we were talking about before, with being able to punch something really hard without being afraid that it's going to hit your hand, or jumping on those plyometric boxes, right? We want them to feel comfortable that they can move forward and run fast as they possibly can in the safest possible manner without getting injured. So we need to clear that path for them. And again, we can get wrapped up in the science on this type of stuff and forget that it's really designed for us to be better at helping people, right? This science behind what we do is the science of helping people, but we never talk about that part, which is the part that drives me crazy, because that's what we are. We are the people that should be the best at understanding the science of helping people.